A couple housekeeping things first. The handouts you have are much longer than what I'm actually going to present to you. What I gave you was what I used for an all-day workshop, and there's additional materials rather than what I'm going over that I thought might be useful for you to have. So I'm not going to try to do 6 hours in an hour and 45 minutes, I promise you. But I want you to have those. And as Catherine mentioned, I included a copy of the secondary traumatic stress scale. You're free to use that. You're free to make as many copies as you want. We'll talk about it a little bit more later, but it's a useful instrument to assess your own trauma symptoms or to do research around secondary trauma, and it's something that I would like people to use. There's no charge or anything like that, so enjoy it. The second piece is my presentation style is I certainly have a PowerPoint. There are things I want to get covered, but I really like to be as interactive as possible. Don't worry, there's not going to be any warm, fuzzy experiential exercises, but I do invite you to ask questions and share your own experiences. I'm going to leave plenty of time at the end for questions and discussion as well, but throughout the process, I'll ask if you have any questions, but also feel free to interrupt me, because I can talk to myself all the time. I'd rather talk with you and kind of hear your perspectives, and I usually get really good research questions and ideas from doing these presentations. So, with that being said, let me ask initially, how many of you here are currently practitioners? Okay. Yeah. All right. And how many of you practice in a solo setting? Any of you? Okay. All right. A couple. Kind of, sort of. All right. Okay. I'm just trying to get an idea of who's out there. Okay, so let me start first with talking about giving the context of what we're going to be talking about. As the field of traumatology has emerged over the last 40 years or so, it has become pretty obvious to most people who do research and practice that there is some personal cost to doing clinical work with traumatized populations. For many years, this was relatively unrecognized. The first person who really wrote about secondary traumatic stress, did not call it that, was a woman by the name of Sarah Haley, who was a social worker at the VA in Boston, who worked with returning Vietnam vets at the time. And she wrote a seminal article called "When the Patient Reports Atrocities," in which she first was one of the first people to kind of talk about what Vietnam vets or what combatants experienced in Vietnam, but also talked about her own experience and her colleagues' experiences in hearing about those issues and working through them. After that, there wasn't really much talk about it for a long period of time. And it was in the early 90s that Charles Figley and Lori Perlman kind of independently started talking about this issue of what happens to the therapist or to the clinician when they are working with traumatized populations. Lori Perlman did a lot of work around childhood sexual abuse, and Charles Figley did a lot of work at that time around Vietnam veterans and other military survivors. But as with PTSD, what emerged in the literature was a lot of people started to recognize this and put their own terminology on that. And that's what this slide is. There are a lot of terms that have been used to describe this experience of a negative impact of working with traumatized populations. These ones in red are the ones that we're really going to talk about today. That these are countertransference, burnout, compassion fatigue, vicarious trauma, and secondary traumatic stress are really the terms that have emerged to talk about this issue. And so those are the ones I'm going to talk about first. And what I want to do first is talk about conceptual issues and what is it we're really talking about, and give you an idea of how I use these terms. There is some disagreement. I don't know that I'd say disagreement, but there's some different uses of the terms out there in the literature. So I'm going to give you my perspective, and that is the right one. But first, let's talk about who is at risk for secondary traumatic stress. The majority of my focus today will be about you all, about social workers and other clinicians who work with traumatized populations. But the issue isn't limited to clinicians. Certainly clinicians are at risk. Any sort of helping professional that engages in dialogue with people who may have experienced traumatic events may be at risk. So there have been a number of studies out there documenting this, and there have been studies on social workers, on child welfare workers, substance abuse counselors, nurses, sexual assault or domestic violence workers, and advocates, and there's an emerging literature on teachers as well. And there's others that I haven't even mentioned there. Another area of individuals who may experience secondary traumatic stress are family members and friends of people who've experienced trauma. And this is actually an area in which the research first emerged, particularly in two areas, looking at spouses and children of Vietnam vets, and looking at children and now grandchildren of survivors of the Holocaust. And it was really this research that resulted in some of the changes in the DSM criteria for trauma that I'll talk about in a minute. And then there's another category which really includes all sorts of other people that may be secondarily exposed to trauma. I have three here. One is researchers. So research assistants or researchers who work in the area of trauma and are hearing these stories, especially when qualitative research is done and in-depth interviews are being done, where they're hearing these stories and they're hearing in-depth discussions and descriptions of traumas that people have experienced. And in that process and hearing it, they visualize and they internalize those events. Support staff, agency support staff in particular I'm talking about here, but there may be other support staff. So, the receptionists, the people who transcribe case records, people who do auditing and TQM stuff, who may be reading records or assessments of people who've experienced trauma. And this is a group that I think gets forgotten about an awful lot. We don't think about their need for self-care being in an environment where they may be exposed to some very difficult things. And then there have actually been a couple studies of jury members who've heard cases of particular atrocities that may be experiencing secondary traumatic stress. So I say all this to say that, the issue really is that you can experience PTSD essentially, or have symptoms of PTSD due to indirect exposure to trauma in whatever mechanism that may occur. So the first term I want to talk about is secondary traumatic stress and compassion fatigue. And I put these together because they're actually supposed to be the exact same thing. Charles Figley coined both terms in the early 90s. He initially introduced compassion fatigue around 94, 95 because he was concerned that the concept or the term secondary traumatic stress, and sometimes he used secondary traumatic stress disorder to refer to people who've experienced secondary trauma to such a degree that they might merit the diagnosis of post-traumatic stress disorder. His concern was that clinicians would find that to be too pathologizing and that they'd be reluctant to identify themselves as having that experience and seeking the help that they might need. And so he introduced the term of compassion fatigue, thinking that it might be more user-friendly, perhaps, for people to identify as. But he's very, very clear in what he's written, and when I've spoken to him, that for him, secondary traumatic stress and compassion fatigue are the same thing. I emphasize this because it's not what you'll always see in the literature, because there are some folks who write about compassion fatigue being secondary traumatic stress, so what I'm going to talk about in a minute, in combination with burnout. And so I'm going to talk to them about how those are different. But secondary traumatic stress, and this is the right view, again, is the same thing as compassion fatigue. I prefer to use secondary traumatic stress as opposed to compassion fatigue for a couple reasons. Primary amongst those is that compassion fatigue has been used for a number of things, not just the fact that for some people it includes secondary trauma and burnout, but it has also been used in journalism and media studies to reference the fact that the public may experience fatigue in hearing about extreme events, and that may be traumas. It may be extreme poverty. It may be all sorts of things. And I think that's actually where it first emerged, was that the public was experiencing compassion fatigue about hearing about the homeless several decades ago. Or a couple years ago, following Hurricane Katrina, I live in Athens, Georgia, just outside of Atlanta, and I opened up the Atlanta Journal-Constitution, which is the main newspaper down there, and there was a big headline that said compassion fatigue. And I was initially excited, hey, this is getting coverage. Then I was bummed out because no one contacted me to comment on it, so my narcissism arose there a little bit. And then I read it and realized it wasn't about what I talked about. it was about this issue of people were getting tired of hearing about Hurricane Katrina at that point. It was about 6 months after it. So that's one reason, because compassion fatigue means a number of different things, and secondary traumatic stress is really limited to one narrow area. I have recently begun to notice that compassion fatigue is starting to be used in a way that I would use caregiver burden. And so there's certainly some similarities between that. I mean, there may be secondary traumatic stress and caregiver burden, but that's also a slightly different aspect. So, secondary traumatic stress. Okay, so what is it? So Figley says that secondary traumatic stress or compassion fatigue is the natural consequent behaviors and emotions resulting from knowledge about a traumatizing event experienced by a significant other. It is the stress resulting from helping or wanting to help a traumatized or suffering person. And I read this to highlight a couple pieces of this. The first is that second and third words. It's the natural consequent of doing this work, essentially. And he has very specifically said that, and I usually specifically highlight it because the issue is that this happens. People who do this work, who work with traumatized populations, will experience, most will experience some symptoms of secondary traumatic stress at some point, especially early on in their careers. That's not to say that everyone will experience it to a degree that they have impairment or dysfunction, but that this is a normal process that emerges in doing this work. And if we recognize it as normal and embrace it as normal, it's easier to deal with it. And it's easier for people to come forward and work through the issue and get the help that they need, and for organizations to then put into place resources and mechanisms to help prevent it amongst their staff. So it's a normal occupational hazard of doing this kind of work, as far as I'm concerned. And then the second piece is that it's a syndrome of symptoms nearly identical to PTSD, except that the exposure to the event is indirect rather than direct. Okay. And so the result of this is that you can meet the criteria for post-traumatic stress disorder, as I said previously, by being indirectly traumatized and only indirectly traumatized. The criteria for the DSM has changed over the years. In the DSM-3, you very clearly had to directly experience a traumatic event to meet the criteria for post-traumatic stress disorder. When it moved to the DSM, I'm trying to think if it was 3 or certainly 4, the wording changed such that you could be, it didn't say it as clearly as this, but it says, I think, experienced, witnessed, or was confronted with essentially a traumatic event. And the confronting with would be learning about it from your clients, or being a spouse or a partner or a family member of someone, so learning about it indirectly. I'm going to come back to that in a moment, because DSM-5 is changing a little bit more. Okay, so is that definition clear? Secondary traumatic stress, in my book, is essentially what we're talking about when we talk about post-traumatic stress disorder. What I think is important to emphasize is the extreme of meeting the criteria for PTSD is just one subgroup of people who experience secondary traumatic stress, and that's an extreme case. There's a lot more people who may experience secondary traumatic stress that begin to experience distress and dysfunction, but may not meet the diagnostic category, and that's an important piece there as well. So probably most of you are fairly familiar with what PTSD is and the diagnostic criteria are, but I'm going to move through them a little bit to kind of put it in the context of secondary trauma. So the first criterion has to do with the exposure and response to the trauma. And so according to DSM-4, it's, you've exposed to a traumatic event where they've been experienced, witnessed, or confronted. So I just mentioned that. There's been a change, or there's a proposed change with the DSM-5 with the exposure criterion that I'm fairly happy with, in the sense that it more directly addresses the indirect possibility. So if you look down here, from here on down is really about, not witnessing, learning about and experiencing repeated or extreme exposure to details about the event are about secondary traumatic stress. And what's positive about that for me is that, one, it's recognized, and then this makes services available for folks who are in that extreme category. It also means that the research around clinicians as well as spouses and children and so on has really had some impact on the field, that we are now recognizing this. Okay. So the next criterion has to do with intrusion, or what's sometimes termed the re-experiencing symptoms of trauma. And so this is kind of the classic: having nightmares about the traumatic event, having unwanted thoughts or feelings or responses to memories or triggers of the traumatic events. So in terms of secondary traumatic stress, what does this mean? This means that a clinician may have their own nightmares or bad dreams about client-specific traumas. They may generalize to dreams or concerns or thoughts about the similar traumas happening to themselves or to their family members. But it's an intrusion amongst one's own life, kind of an unbidden intrusion amongst one's own life around client traumas. So thinking about that in contexts that you wouldn't normally think about. Okay. Avoidance symptoms. So these are specific efforts to not be reminded of or to forget aspects of the traumatic event. So in primary trauma or directly experienced trauma, it would be your own trauma. Secondary trauma, it would be avoiding thoughts, feelings, or conversations around our clients, the people that we've worked with. An inability to recall an important aspect of the trauma. So one of the things that has been found in some qualitative research is clinicians talking about, and often it's a supervisor that catches it, that they have completely blocked out or not recorded details about the traumatic event that their clients are working with. Yeah?
Does this also fit, just out of curiosity, for a clinician who actually has their own trauma experience?
The second, yes.
Yeah, I mean, so it's like you're getting recalls from your own issue and whatever the client's like. Does it fit too? Does this fit for that too?
Well, this is a good question. There's a couple aspects of that. The secondary exposure could very well trigger recollection of one's own trauma.
I mean, I'm a suicide survivor, so
yeah.
I'm particularly interested in this, and what I'm hearing is different than what I thought was about. What do you mean so applicable?
Mm-hmm.
So, and I'm trying to wrap my mind around how it fits for both potential things that I experience.
Yeah. Yeah. Well, certainly one of the aspects, it gets a little tricky in parceling out what's an individual's own direct trauma experience and their secondary traumatic stress experience. And that's a really, really important question, actually. And it's one of the things that some research on secondary trauma has been criticized for is, are we measuring secondary trauma, or are we really measuring their own direct trauma in some aspects? There's a great body of research on police, firefighters, and emergency medical personnel around secondary trauma. But is that what it is? Or these are people who show up on the scene and see the guts and gore. So is it primary or secondary? In the case that you're talking about, there may be the initial trauma, so there may be primary trauma that the secondary exposure then triggers. There's also room for the fact that someone has been directly traumatized at some point in the past, but that wasn't problematic for them. That they didn't really experience symptoms, or certainly not to an extreme. But then once they start doing the clinical work and are secondarily exposed, then they begin to experience dysfunction or distress or impairment. So in that case, it's a little easier, I think, also to say, well, it's not really the primary trauma contributed to it, but it's not primary trauma that you're experiencing. It's due to the secondary trauma. Yeah. Does that help? Yeah. Yeah. Very good. And I'm going to talk a little bit more about personal trauma as a risk factor a little bit later on as well. So thank you for the question. It's the avoidance symptoms that can, I think, really be the last batch, the intrusion symptoms, I think, are often the symptoms that the individual experiences as more distressing than some of the others, than the avoidance and largely the arousal symptoms. But what I believe is that the avoidance symptoms are the ones that are have more of an impact on the quality of the clinical work and the impact of the agency. Because what avoidance can do is result in clinicians, having increased tardiness, absenteeism, not delving into some issues in the clinical process with some clients that they really should to be effective and competent, because that is too painful for them. And it may not be across the board. It may not be that they don't want to deal with trauma at all. It may be a very specific trauma, or there may be details or factors with a particular client that makes it difficult to be effective with that client, but they can be wonderfully effective with some other clients. But this is all related to the avoidance symptoms, where they're avoiding triggering their own reactions to those sorts of things. Does that make sense? Okay. And then there's the arousal symptoms, which are largely classic anxiety symptoms, insomnia, irritability and anger, difficulty concentrating, hypervigilance, so being excessively on guard for danger, and an exaggerated startle response. All right, so I've given you the definition of secondary traumatic stress and compassion fatigue, and they are exactly the same, and you should use secondary traumatic stress, right? Okay. And so the other term that's used often is vicarious traumatization. And vicarious traumatization is a concept that was introduced by Lori Perlman and her colleagues. And, I won't read through the entire definition, but essentially what Perlman talks about is that in doing trauma work over time, and her experience is largely around childhood sexual abuse and sexual assault in adults as well, but largely from that perspective. And so what she found and what she started to describe was that there are profound changes in therapists' view of the world, their conceptual framework, their cognitive schema, is the terminology she uses a lot, around the world, that results from hearing over time these traumatic stories. And that, so the people are vicariously traumatized through their work. So again, it's an indirect trauma. What's different, how she describes it differently, in that she focuses on these cognitive shifts and changes in how we view the world, whereas Figley and the secondary trauma, early secondary trauma literature really largely focused on the DSM-4 type symptoms. Okay. For me, we'll get there. Okay, let me do this next one first before we get there. Okay, so the cognitive schema, the cognitive distortions and disruptions that occur in vicarious trauma. So Perlman talks about two broad categories of these. One is the frame of reference. So clinicians who work with traumatized populations may very well change their frame of reference in three ways. One has to do with their identity, so that over time in working with traumatized populations, we may begin to view ourselves quite differently than we used to. And that can occur on a number of different levels. It may be on a personal level, it may be on a professional level. For instance, I may over time question my competence or my effectiveness as a therapist over time in working with these populations. Again, contextually, she worked with largely childhood sexual assault survivors and some very serious cases, people who have PTSD that's fairly intractable. And so for what she was seeing is therapists who became very, very frustrated over time, feeling that they weren't having an impact. Some very talented and experienced therapists. So you begin to question their efficacy. It may also have to do with personal identity. The example I like to give of this is myself. So being a man, if I'm working with people, especially, again, childhood sexual assault or adult sexual assault, especially, who's largely the perpetrator? Men. So if I'm working in sexual assault and I'm seeing that over and over, I might begin to question my own goodness, my own motives as a man. Am I capable of doing such a horrific thing? Are all men capable of that? And so really see myself somewhat differently than I did before doing the work. Does that make sense? Okay. So then, and in some other ways. So identity has to do with about who I am. Worldview has to do with what's the world like? How do things operate? And spirituality has to do with connectedness and meaning. So connectedness to family, to colleagues, to society, to a higher power. Okay. The next piece is psychological needs, so that there may be changes in psychological needs. Laurie Perlman believes that we all have 5 basic psychological needs, and those revolve around safety, trust, esteem, intimacy, and control. So we all have needs to feel safe and to feel that the people that we care about and we love are safe. And that when we have been exposed to trauma over and over indirectly, we begin to question whether we and our loved ones are safe. If these horrible things can happen, then they can happen to anyone. And so we might begin to take measures to be overprotective with our children, for instance, or to be overprotective with ourselves. We also have a need to trust ourselves, to trust others, and if we're not feeling safe, we may not trust people at all, or that may change. An example I like to give that actually doesn't, I think it helps illustrate this, but it's not really about trauma. My background is in mental health and substance abuse. I worked in residential substance abuse treatment for a number of years. Any of you work in substance abuse treatment? Okay. So when I first entered the field, I changed my ability to trust others changed very dramatically. Because I don't know if you know, but sometimes people who are in addiction lie. They don't tell the truth. They're used to getting one over. And so I got so socialized to questioning what people were telling me. And it then generalized to outside of that. And at one point my wife said, "Listen, hon, not everyone's lying to you. You know, we've known this person for 10 years. They're not lying to you." So, but that would also occur within the context of trauma. So not trusting that everyone's motives and those sorts of things. So safety, trust, esteem, intimacy, and control. I think you can begin to fill in those gaps a bit. I do want to make a comment about where the initial work for this came from. There's a woman named Ronnie Jana Fullman who wrote a book in the early 90s called Shattered Assumptions. And at the time, I think she was probably one of the first to be in talking about this, that for her, the main thesis was that PTSD largely came from a significant cognitive dissonance that emerged in people who experienced severe trauma. And that cognitive dissonance was that we all have some basic assumptions about the world. Some of those assumptions are that the world is essentially safe, that people are essentially good, that bad things don't happen to good people. So that when people experience significant trauma, especially when they're in the perpetrated trauma, so like sexual assault, random acts of violence, and so on, that completely shatters those basic assumptions that we've operated with in the world. And so now we're faced with a very different worldview than we had before, and that creates a significant cognitive dissonance that then emanates in traumatic stress symptoms. Okay, and so that's really the foundation for what Laurie Perlman is talking about. Okay, so you've all hopefully heard the story about the 5 blind men touching the elephant and describing what they feel, So, this guy's saying it's a spear. This guy's saying it's a tree trunk. Guy with the tail saying it's a snake. But they're all describing an elephant. So for me, that's what all these different terminologies are. So vicarious traumatization and secondary traumatic stress are describing the same phenomena, a process of indirect trauma. Okay? They're focused on slightly different aspects of it, where VT talks largely about the cognitive distortions and secondary trauma talks about largely the PTSD type symptoms. But it's all the same phenomena, they're just talking about different things. So for me, secondary traumatic stress encompasses vicarious traumatization, compassion fatigue, secondary traumatic stress. It's just a matter of preference as to which term you use. Does anyone want to fight with me on that? Yeah. Okay. All right. But there are a couple other terms that get thrown about. One is countertransference, and the second is burnout. So let me talk about those a little bit. Any heavily psychodynamically oriented folks in here? I want to see if I'm going to offend people first. But no, I was trained cognitive behaviorally, so there's some value to psychodynamics. But I usually have to watch what I presented some of the stuff up at Smith College one time, and they were really psychodynamic, so I had to watch it. I had to change my presentation a bit. So there have been, especially psychodynamic folks, who've said, is this just countertransference? There's actually a little piece out there that a psychodynamic social worker wrote that secondary traumatic stress isn't just old wine in new bottles. So there is a belief amongst some that we're just talking about countertransference. Up here is a reprint of Freud's one of his original definitions, that countertransference is a distortion on the part of the therapist resulting from the therapist's life experiences and associated with his or her unconscious neurotic reaction to the client's own transference, which is what the client is putting out there about the therapist. Well, countertransference as a term has evolved quite a bit over the years, and so each one of these is kind of a different iteration. Let's go down to the bottom one here that Perlman uses, which is that countertransference is any response a therapist has to his or her client, positive or negative, conscious or unconscious, spoken or unspoken. So what isn't countertransference according to this definition? And so that's one of my problems. If countertransference is really any sort of reaction you're having to a client, it becomes so general that it's really not a useful description for what we're talking about. That's one piece of it. Another way that countertransference is different from secondary traumatic stress is that countertransference, and I don't argue that countertransference exists. I actually believe it's a really useful concept, and certainly early on was to describe some of the interpersonal dynamics that go on. But countertransference can be experienced with any client population, with any client. The original definition would limit it to clients that have some of the similar issues that we experience in early childhood. And the implication of that would be that only people who experience their own traumas, and probably the traumas similar to the client, would experience secondary traumatic stress. If you're being triggered by your own experiences, wouldn't you then have to have experienced trauma yourself to experience secondary traumatic stress? And that's not the case. You can experience secondary trauma without having had significant problems with trauma. So countertransference is broad. It can happen with any client. Secondary trauma, it has to be with traumatized clients. Countertransference is limited to that the therapeutic relationship within that context and really within that time period where secondary traumatic stress begins to have an impact outside of the therapeutic relationship. So some of the things that we've seen, irritability, trouble sleeping, avoidance, overprotectiveness, begins to have an impact on interpersonal life, especially with our family and our friends. Countertransference doesn't really do that, doesn't begin to impact our social life, or could impact our professional life, but less our social life. Any questions on that? Any arguments? You're allowed to argue with me. I welcome it. Okay. All right. So the other piece that is bandied about is burnout. And we're all familiar with what burnout is. Largely, burnout is a syndrome of emotional exhaustion that comes out of, I think they use, people work of some kind. Curiously, burnout is also a term that has become so generalized in common usage. But Maslach was one. There have been several people in the burnout field who've come back and said, listen, this is getting too broad. This is really what we're talking about. It's really about emotional exhaustion, seems to be the key component, and it's really about doing work in specific contexts. And a key piece of burnout is it has to do with organizational dynamics. So it's not, although it happens with people work, the main issue, the main cause is excessive demands on the worker, the clinician, in the context of inadequate resources provided by the organization. So it's not really about the client and what the client brings to the table and how the therapist reacts to the client. It's that the therapist or the clinician is doing very difficult work, which is emotionally draining, but has so many time demands due to paperwork, all sorts of organizational stuff without the organizational responsiveness and support to be able to process those issues and deal with and recover from the emotional aspects of the work. So it's not about the client. And again, burnout, like countertransference, burnout can happen with any client population. It doesn't have to be limited to trauma, whereas secondary traumatic stress is limited to trauma. That's not to say that there isn't a significant relationship to the two. There is a lot of correlation between secondary traumatic stress and burnout. And certainly to me, conceptually, that makes sense. If you're experiencing secondary traumatic stress, you're going to be much more likely to experience burnout. And it may be the other way as well, that burnout puts you at risk for developing secondary traumatic stress, because then you're putting less effort into working through the issues you need to work through. Okay? All right. So any of you remember high school math and Venn diagrams? So this is what I've put together. Because, again, I believe countertransference is out there. I certainly believe burnout is out there. And all these things can happen together. So talking about these things are conceptually distinct. And the research is bearing that out. There's been some emerging research around burnout and secondary traumatic stress. Although I will say some people interpret it differently than I do. But for instance, some of the research has shown a correlation between measures of burnout and secondary traumatic stress on the magnitude of, say, 0.5 to, I've seen one up to 0.7. Well, in the social behavioral sciences, that's a pretty strong correlation. But we would expect there to be a correlation. So we're not talking about secondary traumatic stress in some completely different concept. You would expect there to be a high correlation. But if it were at 0.9, then we might begin to say, okay, maybe these aren't two distinct concepts. But my interpretation is those are very strong correlations. There's some co-occurrence of those, probably a lot of co-occurrence of those, but that's not so high that I would say that we're talking about the same thing. So there could be someone right about here who's experiencing countertransference, burnout, and secondary traumatic stress, including the cognitive changes from their work. There could also be someone that only experiences burnout without the secondary traumatic stress. Yes? That's a good question. There's no explicit guideline, but burnout is more of a longer standing experience. So a day, no, you're having a bad day. I prescribe going home, getting some sleep. And, if you drink, have a glass of wine. But you'll probably, take the weekend. You'll probably be all right. Now, burnout, it seems to be, it emerges over a longer period of time. And that's also one distinction with secondary traumatic stress. You could go, especially newer workers who are going to be more at risk because they haven't yet been able to develop the coping mechanisms, may be fine, no secondary traumatic stress symptoms, see one client that day who's experienced some horrendous traumas and go home and have nightmares that night and dream about it and not be able to stop thinking about it. May resolve after a few days. But burnout, you're not going to go have a bad day and then come home and say, I'm quitting this job, which is kind of often where burnout goes. So it's a longer standing. The other implication of that is that burnout also is more difficult to recover from. And people do. It's not like once you're burnout, you need to leave the field. The problem with burnout is often people are stuck in the settings that they have less control over the cause. If the cause is really about institutional support and resources, you have much less control over it than you might in secondary traumatic stress. Is that what you were getting at? Does that help? No specific, no. Other thoughts or questions? All right. So let's talk about, we talked about the specific symptoms. Let me just point out a few other ways. Because the A, B, C, D, E, F, I think the F criterion for PTSD is you can have these symptoms, but you also have to have clinically significant distress or impairment in social or occupational functioning, right? So that's where secondary traumatic stress may begin to lead. So what's the interpersonal impact of secondary traumatic stress? And I kind of alluded to this a few minutes ago. Well, by experiencing secondary traumatic stress, especially if we think about kind of the vicarious traumatization concept and what that adds to the mix, is that there are changes in how we see the world and then how we relate to the world, which then leads to how we interact with the world in our interpersonal relationships. For some folks, we may become withdrawn and isolated, and that's kind of a classic PTSD symptom. We may become very mistrustful of others, even within our families, perhaps. May become isolated, can have a big impact on parenting. Some of the people I've talked to in doing workshops over the years, I've gotten multiple examples of people, especially with teenagers, come up and say, you know, I'm experiencing this, or I was experiencing this, and got in a big fight with my teenager because I was being too controlling. I wouldn't let him do things that I previously did or would have, and those sorts of things. So we may become, in some respects, it becomes, often I think it results in kind of really overprotectiveness and controlling of the children. It may involve completely isolating our children, for instance, from others, not allowing them to do things with people we might have previously allowed them to do with because we become mistrustful, those sorts of things. There may be projection of anger or blame, and this can occur in a number of ways. It can occur within our interpersonal relationships. It can occur at work. Often this is also will have kind of a societal focus. Intolerance was kind of related to the anger and loneliness. And then there's a professional impact that I think is really important to consider. You'll hear me in a little bit. Part of my soapbox these days is the organizational obligation to provide resources and efforts and supports for clinicians to help minimize secondary traumatic stress and burnout. And the reason, part of it, I think my avenue in, is that, well, this has an impact on the individual clinician and their effectiveness, but it also has an impact on the organization and how well that organizations can deliver quality and effective services. So the professional impact may be a decrease in quantity and quality of work, and especially the importance of quality. Think about the issue of absenteeism and tardiness and poor documentation and not addressing some of the things that we need to do clinically. There may be low motivation amongst the staff, avoidance of job tasks. So I gave the example earlier of kind of not asking the questions or not hearing the stories that you might need to in doing trauma work. Many of you may be in agencies where you're not specifically doing trauma therapy, but you're definitely working with traumatized populations. So, not doing a part of a psychosocial assessment, for instance, that really has to do with trauma and abuse and those sorts of things. It may result in low morale, negative attitude, or apathy in an individual, or that may be, if you're in a setting where there's a lot of trauma exposure, indirect exposure to trauma, all your colleagues or many of your colleagues may be experiencing this. So there may be some sort of organizational secondary trauma that's going on. Decrease in confidence, a decreased ability to be empathic. We're pretty clear that empathy is an important part of what we do, right? We need to be empathic. We need to be empathic to be effective. I like to say empathy is an evidence-based practice. It's an important part. But part of our understanding of, from early days and from the beginning, Figley and Perlman have talked about empathy as being the primary mechanism through which secondary trauma emerges. That it's by being empathetic that we are at risk for secondary traumatic stress. I'm by no means in support of educational programs teaching people to be less empathic. It's not really what we're about, but there's some other things that we need to do. So if people's empathy decreases, they're going to be less effective, and that's really where I'm getting at there. We don't yet have evidence of secondary trauma contributing to actual turnover because there just haven't been studies that have been able to look at that. But we have a number of studies that document a strong correlation between secondary traumatic stress and intention to leave the organization and or the field. So that there's what's called turnover intention, so that there's a very strong relationship there. And certainly a high rate of turnover has an impact on organizational effectiveness and the quality of services that are delivered. Okay. Any questions so far? Any thoughts? Yes.
Does over-identifying with a client issues come into play with any of this? Because a couple times I'm listening and I'm like, well, what if they're just over-identifying?
Yeah. All right. What do you mean by over-identifying? Can you define that for me?
I guess in that the person telling their trauma, I guess it would be definitely from a counselor who has experienced the same kind of trauma, and not necessarily re-triggering their own trauma, but they're like, yes, I understand what you're going through, kind of thing. And is there?
Yeah.
Maybe it goes back to my original.
Yeah. Hold on to that because I think I'm going to get there for you. Okay. All right. So for a long period of time, the secondary trauma literature, again, Figley and Perlman kind of entered this in the early 90s and 90s. The next 5 to 10 years, there was really this burgeoning of articles in literature on this topic. It was something that's of big interest to clinicians. Usually I do workshops and I see heads nod quite a bit when I start going through these symptoms. So anecdotally, we've always known that it's been there. But for a long time, there wasn't much empirical research really documenting that it was the case. It was really anecdotal, based on interviews or experiences or people kind of just informally talking. But in the last 10 years, there's been more and more efforts, and I'm biased. I'm reporting on mostly on my stuff, but there's one others. But I'm not the only one. So there's been much more effort to document that this is actually occurring. And so there's really no doubt, because earlier on, people might question, okay, sounds nice conceptually, but is it really happening? There's really no doubt at this point. I've done several studies, one with kind of a general sample of social workers, one with substance abuse counselors, and one with child welfare workers. I'm also going to talk a little bit about this one with emergency room nurses, which I had little to do with. But it's another group that's being studied a lot now, is emergency room nurses and ICU nurses. And hospice providers are starting to emerge as a population that's being studied as well. So the reason why I picked these four is they were all used the same instrument, which is the one that you have, the secondary traumatic stress scale, which was developed to be congruent with the DSM-4 symptoms of PTSD, with the words very specifically worded for those in which they could, that the trauma or the symptoms were related to client traumas. And that was done to try to distinguish secondary trauma from direct trauma, that we're not just measuring any trauma, we're measuring trauma related to the clients. And as you look through that, you'll see there are like 7 or 8 items that say my client's trauma or that sort of thing. So using the same instrument, we can compare a little bit. The other nice thing about it is because it's related to the 17 symptoms of DSM, you can use a scoring approach to kind of see if they to estimate the rate at which they meet the diagnostic criteria as well. So that's one of the things that we've done in most of these. So with social workers, and this was a sample of folks, all licensed social workers in the state of Georgia, so some of which were administrative, most of which were clinical, but varying levels of clinical practice and populations. 55% met at least one of the 3 main criteria for PTSD. 24% scored above the clinical cutoff, which is 38 if you use it for yourself. I'll come back to that in a minute. And 15% met the core criteria for PTSD, which is that they met the criteria for intrusion, avoidance, and arousal. With substance abuse counselors, 57 met the core criteria, 29% above clinical cutoff, and 19% met the core criteria for PTSD. So before I go on to the next 2, let me clarify something. So when I say that 19% met the core criteria for PTSD, the way that instrument is worded, as you'll see, is symptoms in the past week. So we're talking about point prevalence. We're talking about people's current experience of trauma. The lifetime prevalence of PTSD in the general population in the U.S. is 7 to 8%. It means 7 to 8% of the population has experienced PTSD at some point in their life. If you were to ask them, and if any of you have references, I can't find one that looks at PTSD point prevalence, but it's going to be a lot less than 7% because that's 7 to 8% across a lifetime. This is 19% for substance abuse counselors in the last week met the criteria for PTSD due to secondary trauma. Look at emergency room nurses and child welfare workers. A full third of them met symptoms that may be of diagnostic level for PTSD in the past week. That's a lot. That's a lot. I will give a little caveat in that we still haven't done a these are based on a scoring criteria that is kind of standard, well, not standard, but has been used with different instruments. To really know if these hold, we would have to give the secondary traumatic stress scale with a in-depth clinical interview to basically diagnose PTSD due to secondary trauma and compare these results with that, and we haven't done that. So these may be overestimates, but I'll tell you what, if it's half of 33%, and it's 16% compared to 7 or 8 over a lifetime, that's pretty significant. Okay. So, yeah, I mean, the medical field, nurses and doctors, I have 2 good friends who are ER docs, and on one level, it's a protective mechanism. As social workers, were horrified by the fact that we would treat someone like that. But I think to some degree it's a protective mechanism. Whether it's an effective protective mechanism is open to question, and maybe this is telling you a little bit about that. We don't know yet. So thank you for that observation. Yeah. All right. So now let's talk about risk and protective factors. So what leads to secondary traumatic stress? I mean, obviously, exposure is the key variable. You have to be exposed indirectly to trauma to experience secondary traumatic stress, obviously. But what does that mean? And that can mean a number of different things. And in the research, exposure has been operationalized in different ways, some of which can show very different results. One measure has been size of caseload. And size of caseload kind of has a mixed result as to whether it's correlated with secondary traumatic stress. The difference in whether, I haven't, this is occurring to me as I'm talking, I haven't sat down and looked at all of them and determined whether this is the case. One of the issues with this as an exposure variable is it has to do with the mix of the caseload. So if we're talking about, sexual assault counselors, where every client is, or child welfare workers, where every client is traumatized, then size of caseload makes sense as a variation in exposure. You're being exposed to more people. But if you have a wide caseload, if you're in some sort of setting where not everyone is traumatized, caseload may not be a really good indicator of exposure to trauma, because you might have one person who has 20 clients, another person who has 100 clients, but they both have 2 traumatized clients, right? So it would make sense that doesn't always work. Some other measures of it has to do with percentage of time spent in doing trauma work, the severity of trauma amongst the client population, the percentage of their caseload, rather than size of their caseload, the percentage of the caseload that's been traumatized, those sorts of things. And when you get more and more specific like that, the results tend to be more positive in the sense that we find the relationship more often. One variable that has been proposed early on as something that is a particular risk factor is exposure to people who've been traumatized as children, whether they be children at the time that we see them or adults whose traumas occurred in childhood. And so the hypothesis has been that in those people who work with those populations will have higher rates of secondary traumatic stress because And think back to what I talked about shattered assumptions and our belief in protecting children. That we see it as more of an affront for children to be sexually assaulted, for instance, than adults. Not that it's okay either way, but that we feel so protective of these vulnerable populations that it makes it more difficult for us to comprehend, which makes it us more prone to the symptoms. What the research is, with research everything's a little mixed. What I see it as bearing out is that it's less the case if there's an adult who was traumatized as a child, but if you're working with child trauma patients, that really does have an impact. That those folks really are at higher risk. Okay. The research has looked at a number of demographic variables. I'll say right off, so we don't spend too much age, discipline, meaning social workers versus psychologists. There haven't been many studies that have done that, but a few. Educational level, there's really no relationship between those and levels of secondary traumatic stress. So those aren't particular risk factors. It's mixed, but there have been some studies that have shown gender is related and that women have higher levels or are more likely to have secondary traumatic stress. I'm going to come back to that in a second. And then experience, so that for the most part, studies show that with more experience, there's less secondary traumatic stress. This can mean, it can mean both of two things, I should say, not one of two things. One, it could be we have never conducted a longitudinal study of secondary traumatic stress, so following people new to the field and over the course of 5, 10, 20 years and see how secondary traumatic stress emerges, how they engage with it, how they resolve it, or if they leave the field. So it may very well be that those people who are more at risk or have more experiences of secondary traumatic stress simply leave the field. And then when we do these one-time studies, they're just not in the sample because they're no longer in the field. So that the people who are less likely or have less severe secondary traumatic stress are those with longer experience. Okay, so it may be an issue of selection bias. The other piece, and I think it's probably a little bit of both of these, the other piece is that people longer in the field have had more opportunity to develop coping mechanisms and develop social support networks and all the sort of protective factors that I'll start talking about in a second. So it's probably a little bit of both. All right. Back to gender. Okay, so gender. Women have higher rates of secondary traumatic stress and more severe secondary traumatic stress. There's a correlation between gender and secondary trauma. This room is actually less of a good example than most of the ones I do with social workers in that there's more men in here than usual, but still, look around. It's mostly women. This is the case in most of the studies as well, that the samples are usually about 80% women. So there may simply be an issue of under not having sufficient sample size in men. The other piece is, if you look at the PTSD, the primary trauma literature, initially there was some indication that women are more susceptible to post-traumatic stress disorder. But when you start controlling for the types of traumas that they've experienced, and that women are much, 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 much more likely, though not exclusively, but much more likely to experience sexual assault than men. And sexual assault and combat are the two most likely traumas to result in post-traumatic stress disorder. So when you're looking at samples of women and men, and women are mostly experiencing the trauma that's most likely to result in PTSD, and men aren't, then it would make sense that they'd be more likely to have PTSD. If you start controlling for that factor, for what the trauma is that they're experiencing, the relationship disappears. So there really isn't a gender difference with primary trauma. I did go to one session at a conference once where they actually looked at men and women who had been raped. And men had much higher PTSD than the women who had been raped, which I won't go, goes back to kind of that shattered assumptions thing. Men don't think we're going to get raped. And so when it happens, perhaps there's even more cognitive dissonance that's going on. Okay, so back to the gender issue. It's well recognized that many people in the helping professions there's a higher rate of trauma in people in the helping professions, probably because people experience things and want to help people with the things that they've experienced, right? if you connect these dots, that women are more likely to experience traumas that are more likely to result in PTSD. When they go into social work or psychology, they may be more likely to go in the fields that deal with those traumas. Said reverse, if you look at people who work in domestic violence or sexual assault, many of them have experienced domestic violence or sexual assault, right? And so they're working with the populations that are more likely to experience PTSD, therefore they have some higher exposure, and they're hearing the stories of the things that are more likely to result in PTSD. So to me, that makes sense that there would be, if there is a gender difference, that it would probably have to do with the exposure. Does that make sense? All right. Trauma history is the other. I haven't mentioned that yet. No. Okay. So we've always assumed that someone. This is coming back to your thing. That people who have a trauma history would be more likely to experience secondary traumatic stress, and that hearing other people's traumas would trigger unresolved issues around our own trauma. What's interesting about the research is it's very, very mixed. In some studies, that's absolutely the case. People who have had a trauma history have higher rates of secondary traumatic stress. In some studies, there's no relationship. And in another set of studies, people who've experienced trauma history actually have lower rates of secondary traumatic stress. So what's really going on probably has to do with whether that individual has resolved their own trauma issues. Have they effectively coped with their own experience of trauma? And if they have, then they've developed coping mechanisms, social support networks, all the things that help one recover from trauma and also help prevent secondary traumatic stress. So having a personal trauma history itself may be irrelevant. It's where one stands with how that's affecting your own life emotionally and personally. So that's really kind of the resolution and of the trauma issues, or alternatively, the development of coping mechanisms. So, all right? Okay. Which is good, because most healthy professionals have experienced trauma. Not necessarily PTSD, but trauma. Okay. So, empathy. How am I on time? Okay. So empathy, as I mentioned before, has from the get-go been the culprit. That it's the empathic engagement with clients, especially around their stories about trauma, that puts people at risk. We put ourselves in other people's shoes, mentally and emotionally. Therefore, in some respects, we experience what they have experienced. And so that's how we become traumatized. So that's been the theory. Strangely, despite the fact that this has been written about from day one, there's been very, very little study of the role of empathy in the development of secondary traumatic stress. There's only a couple studies that have started to look at that. I'm going to come to those in a second. Let me move to the next thing because they're related. The other thing, and this also speaks to one of your questions, a related issue, because I think both of these work in concert, is the ability of the clinician or the person to emotionally separate or disengage from the clinical work. The ability to kind of shut it off, to not be a clinician, to be able to consciously not think about the traumas. So, and these aren't mutually exclusive. It's not that you can be, if you're empathic, you can't have emotional separation. It's the ability to kind of regulate and modulate how much you engage with the client, and the ability to not carry that into the next session, to carry that home, to carry that into the weekend. Those sorts of things. Okay? Does that make sense? Yeah. Yeah, it's actually what I was kind of thinking, that that there's a range of identification within the empathy, and that probably the more you identify with the client, It may not be the more empathy, but the closer you get to feeling their experience the way they feel their experience. Yeah. Yes, I would agree. So this is a good question because, like I mentioned, there's actually been only 3 or 4 studies that even looked at empathy. I think all of them have looked at it with the same measure, which is Davis's interpersonal reactivity index, which is a very specific model. There's some new emerging models, and actually a social worker at Arizona State is developing a measure and a model that I think is actually probably better. I haven't seen her measure yet, but we really, we have to look at empathy, period, from a research perspective, but we really have to be clear about there are different aspects to it and begin to really try to look at what part each plays in it. Because the little bit of research that's been done on empathy, 2 of the studies have looked at both empathy and this issue of emotional separation. And when you include both of those in regression models, empathy is not significant at all, but emotional separation in both cases is. So those people who have higher rates of the ability to separate emotionally or disengage, regardless of level of empathy, have lower levels of secondary traumatic stress. The problem with that research is in neither case did they first enter empathy and run a model and then enter emotional separation. So we can't say empathy has nothing to do with it, and I certainly wouldn't expect that's the case, but without the research we can't. My suspicion would be if you just run the model with empathy may be significant, then you run it with emotional separation and it flushes out. So that emotional separation is a mediator for that. Really the research on secondary trauma is so new in some respects. It's really starting to take off now that there's a lot more being done out there right now, and we really have to take these nuanced views. But so the evidence so far shows that regardless of level of empathy, by disengaging, Kevin Corcoran talks about the maintenance of emotional separation, so the ability to do that. In medical schools, they teach doctors to not, to be able to separate, to leave it there, and that may be something that we need to do. Maybe not as drastically as some of the physicians I'm friends with, but the ability to do both, and that's the thing. That's the thing I don't think they necessarily teach in medical school is to do the empathy, but also I think they just teach them to cut it off. But it is for me, and it's this is where I'm going in a minute anyway. I mean, I think one of the most important ways to prevent and to deal with secondary traumatic stress is to be able to turn it off, to be able to go home and leave work at work. And it takes some skill, and it takes some practice, and it takes a lot of things. And it's a challenge in this field because I know some of you came into this field to get a BMW, but most of us did it because we want to help, and we always want to help. And students almost all have the exact same reason why I went to social work. Well, when I was in high school, all my friends came to me for help. So, so I realized I was good at it, so that's what I was going to do. So we like to do it a lot. And then we even feel guilty if we're not doing something that's helping people. But I think it's, if it's going to cause you to leave the field, you can't help people for very long. So it's really, really important to be able to disengage and do things differently. And so, for instance, if you work in child welfare, don't volunteer on a suicide hotline. Don't do those sorts of things. If you want to do a lot of volunteer work, and I think you should, and that's admirable, what I like to do is I do volunteer work with Habitat for Humanity. It lets me channel my anger in socially appropriate ways by hammering things, and it's helping people, but it's not hearing their stories. One way to channel kind of that energy that is beginning to look, it hasn't been studied very much, as helpful is in channeling efforts into advocacy for traumatized or oppressed populations. So where you're less hearing the stories, and you feel empowered that you might be making a difference, which seems to be able to kind of counteract that as well. So be careful in what you choose to volunteer with, but I certainly don't discourage that. Okay. So empathy, emotional separation. There's also this concept of compassion satisfaction that has emerged in the last 5 or 10 years that, to point out that, trauma work has its benefits. Working with traumatized populations is immensely satisfying for most of us. I mean, that's partly why we went into this, is to help people. Makes us feel good. It makes us feel productive. It makes us feel competent. And that compassion satisfaction can help mitigate the impact of secondary traumatic stress. So it's not this bipolar thing that either you have secondary traumatic stress or you have compassion satisfaction. You can be high in secondary traumatic stress and high in compassion satisfaction. And the end result is you may be experiencing secondary traumatic stress symptoms, but that's less likely to translate into you leaving the field, taking that home with you. I mean, it helps mitigate the effects and probably over time, but again, no longitudinal study yet, reduces those secondary traumatic stress symptoms. I have done some preliminary work on it's not compassion satisfaction, but job satisfaction in general. That job satisfaction seems to be an important mediator of the relationship between secondary trauma and turnover and tension, which has some important implications. As I mentioned, I get on my soapbox, organizations need to provide support and resources to help their staff with secondary traumatic stress, to help prevent it and deal with it. But they can also impact their turnover rates by doing other things that may increase job satisfaction that might have nothing to do with secondary traumatic stress. So general job satisfaction helps reduce that relationship. Now, from a clinician's perspective, you don't want to feel secondary traumatic stress anyway. I mean, that's part of it. So increasing job satisfaction may not deal with that, but from an organizational perspective, it may decrease the costs of secondary trauma on the institution. And then another one of the most important pieces is supervision and peer support. Clinical supervision, by providing a forum for clinicians to have a safe, supportive place to process the stories they're hearing, their reactions to their client population, and to deal with those, and to also help them feel competent in working with and being effective with the client population, can really help to minimize or help resolve issues of secondary traumatic stress. And that, for me, an important part of clinical supervision in any setting should be the regular monitoring of secondary trauma and burnout in the staff members. That being said, I think the kind of core ingredient of that is individuals, clinicians, having a forum or a place to process these things, to talk about the painful clients that they've worked with, their reactions to them, their struggle with even having a reaction to it. One of the issues is social workers aren't, and Darcy Siebert at Florida State has done 1 or 2 studies on this, social workers are really bad at help seeking. We tell everyone else to get help and it's okay to go into therapy, but we don't do it. God forbid we go get help. And part of that has to do with the fact that we identify as the experts and the helpers, and we know what to do, so we don't really need someone else to tell us what to do. And if we were to go do it, that may be a sign of weakness. And I'm not saying that this is completely conscious processing, but this is what Darcy seems to be finding. It's important to get help. But one mechanism of help is therapy. Another mechanism is clinical supervision. And another mechanism, which is less threatening often, is peer support. So talking with our colleagues over coffee, over lunch, and while we're charting, at the water cooler, these sorts of things, and really being able to process these. And it's really important to have an organizational culture, whether it's top-down or bottom-up, in which it's okay to talk about secondary trauma and burnout. This is not a weakness. Again, it's a natural, consequent part of doing this work. And so we should be talking about it. And the more we talk about it, the less it's going to be an issue. 1, because we normalize it. 2, because part of dealing with trauma is exposure to the trauma and talking about it, and therefore desensitizing the negative effects from the stories that we're hearing and telling. So, and some, I put both of these together because they're done by different people, but it's really the same mechanism that we're talking about, and that's that support and processing. And in some agencies, in some organizations, it's much easier to get the peer support than the clinical supervision. In some agencies, and if you're an agency director out there, please provide clinical supervision for your staff, but certainly provide a mechanism for them to do peer support. I've found some really, or heard of some very innovative means of people getting this peer support. Some of the people that I've talked with in Georgia who are in very rural settings, they work alone or they cover a county, 5 or 6 county region, where they've developed virtual support groups, or they come together once a month and they rotate the area of the county or the place that they meet. So there are a number of ways to do this. It's not that you have to be in an agency that has a certain number of people or anything like that. But so if I can give a couple take-home points: supervision, peer support, the ability to leave things at work and to have that emotional separation while maintaining empathy. And then, there we go, balance, having a balance right here. So figured we had to have some sort of arrows and graphs and tables here. So let me step back a second. The first step to preventing secondary traumatic stress is being aware of it. Having awareness, one, that it occurs, so at a broader level, and second, how it is or if it is occurring within yourself. So recognizing the symptoms and monitoring your own levels of secondary trauma and even burnout as well. Another reason why I gave you the instrument is you can do that periodically and see if you're changing. And there's going to be some natural fluctuations with secondary traumatic stress. Again, it's not as intransient as burnout. If you've had a week with lots of severely traumatized people, you're likely to experience more symptoms. And if the next week is less intense than that, it might diminish a little bit. I did a workshop with some school social workers in Atlanta, and we happened to meet the week after spring break. So I had them do all this. We were going to process this, and they had very low levels. And someone said, we just got off of spring break. If we took this 2 weeks ago, my scores would have been a lot different. So in some cases, that can make a big difference. It's over time, keeping the peaks up over time and having lots of secondary traumatic stress over time that then begins to lead into the longer term or the more significant problems. So having awareness, monitoring your own levels. Having a balance in your personal life as well as in your professional life. So a balance between professional and personal, leaving out work, exercising, going hiking, playing with your dogs, playing with your children, doing things that are not social work at home. But within your within your professional life, if you have the means of balancing when you see clients or the types of clients you see, or splitting them up to have some time in between clients so that you can process what you've had. So finding some balance. So I don't spend all of Friday with your most traumatized clients, and then the rest of the week was doing paperwork. Spread them out if you can. There's some balance in a number of different ways. And then maintaining a connection with others. So back to that peer support, the importance of peer support. Maintaining a connection with why you went into the field. So remembering that there is some satisfaction out of this field, that you came to help people, and that you are helping people can be really important. And then so you have to have awareness, balance, and connectedness in your personal, professional, and organizational lives as well. So, questions?